All right, everyone, you have made it to our last and final module, Module 6. I'm so excited that you are almost at the very end and you're going to be ready to see patients with special healthcare needs in your practice starting tomorrow. So, this module is about interdisciplinary care, team systems, as well as practice management. I know some of you have been curious about this from the very beginning, especially dealing with insurance, dealing with administrative workflows, how the medical consultations work, how just kind of the business side of this works. And I am really excited to bring all of our business tips to you guys in this module. So learning objectives here are pretty straightforward. We are looking at creating a long-term dental home for these patients in your practice. We are also looking to learn about what the administrative workflows look like, as well as the business benefits of seeing these patients, which I kind of touched upon a little bit in module 1, but I will go over that again in this module and just tie up everything in a nice little bow. What does a long-term dental home look like? It's basically a home where there is predictability, routine, and then an evolution of care is being offered for patients with special healthcare needs. And there's lots of ways in which we can build these dental homes. One of that, and I've mentioned this so many times before, but it really comes down to team training. So every new person who comes into your practice as a new dental assistant, associate, dentist, hygienist, when they're being onboarded, we need to start training them and telling them about what is our approach with patients with special healthcare needs. How do we see them in our practice? Are they comfortable seeing in their practice? Do they need additional education or CE on seeing them in practice? And how you basically do things in your office. You need to tell people who are coming on board about that. Um, I feel like monthly refreshers regarding medical emergencies is critical, and quarterly refreshers for managing patients with special healthcare needs is quite important. If you start to do those run throughs at least 4 times a year, people will start to know what to expect. They will know how to deal with certain behavioral conditions, sensory issues, different kinds of patients with different medical comorbidities, and they will be a lot more confident when they start seeing these patients in their chairs. Morning huddles. I know most of us do morning huddles pretty regularly, but I also know some of us don't. And I, for one, was not a believer of morning huddles for a long, long time until I started seeing patients with special healthcare needs pretty regularly. Almost 60 to maybe 65% of my patients now are patients with special healthcare needs. And believe me, because we see so many of them, sometimes we forget what their last appointment with us looked like. And when we do the morning huddle, it just like a good reminder of, oh, this is what worked with this patient. He likes the ABC song. Or, that other patient, he needs his dad to be home. And if dad is not home, then maybe we need to reschedule the appointment, or let's call up mom and remind her to keep dad at home for a little longer. Something like that. Like all of these things are important because we talk about it as a group. Typically, my lead assistant will walk us through the schedule, and then she will ask us all for our comments that, hey, do we need to have a different approach for this patient? Is there partial in? Is anything pending on their treatment plan? So we'll go over that. And having clear role assignments is pretty nice. So my lead assistant is basically my work wife. She will take care of most things, but maybe in your practice things look a little different. Maybe you have a specific lead assistant who is in charge of managing um, all of the treatment materials. Maybe you have another one who has the heart for ADA, for accessibility, for being kind of the in charge for sensory and behavioral issues that you might see in patients. And they want to kind of take over certain specific cases on your behalf. So let them have that leadership and show their leadership in this. Um, Having those clear role assignments really helps because it empowers people within our office and they start to feel really engaged with our patients. Internal systems, I've mentioned it before, but we have cheat sheets for almost every major medical comorbidity. It helps everyone. It helps me, it helps my dental assistants. We have cheat sheets for different emergencies. It's super important to have them for medical emergencies because I've said it time and again, when stuff happens, your brain can stop working. So you start to go more by gut instinct rather than anything else. And so having that medical emergency cheat sheet can help you a lot. Um, and believe me, these sheets are available at every major hospital system. Everyone has those plastic laminated pamphlets. And de escalation training, what to do if a patient runs, if there's a runner in your office, or what do you do if they start exhibiting self-injurious habits. Our goal, of course, is to be prepared for that even before they get into the room. If they get into the dental chair and they're starting to exhibit this behavior, then you know that something along the line has failed. For example, maybe the person making the new patient appointment um, did not ask for enough details from the family member, from the power of attorney when they were scheduling that visit. So you know that something along your processes has kind of failed, which is why now you're seeing a patient with these behaviors in your operatory and you are not prepared to handle it. In any case, even after that training, even after taking care of that situation then and there, you have to go back and fix that process so that it doesn't happen again. Because again, patient safety and team safety is super duper important um, every day, not just when you're seeing patients with special healthcare needs, but when you're just going into practice every single day. It's the most important thing. Administrative workflow, there are so many different workflows here. So having something like ChatGPT where you can modify your maybe your medical history forms or the kinds of questionnaires that you're handing out to patients can really help. You don't have to reinvent the wheel, and if you use AI, things will be much faster for you. um, I've talked about scheduling strategies before for certain kinds of patients. Certain times of the day are better than others. We also see only one patient at a time. We don't see multiple patients at the same time. It really helps in terms of focus. That's really the way I would recommend all of you should practice, but I know that that's not possible. Some of you are in extremely busy practices. You have multiple hygienists that you're seeing at the same time. So you do have to hop out of your chair and go somewhere else for a few minutes. But have a game plan. If you have a patient with special healthcare needs, try to see them early morning appointments or the first appointment after lunch so that you're more focused and they are your only patient at that time. Prep the operatory, try to keep things that are not necessary out of the way because it's like again when you have a toddler, if you keep too much stuff around, there's way too much stimulation and you're providing temptation to them to like throw stuff around or to play with things that they really should not be playing with. So clean up your operatories, have it look like the cockpit of a pilot where it's just clean and neat and there's not a lot of sources for distraction. And keep internal notes. What did the patient like last time? Maybe he liked a certain song. Maybe he preferred a certain assistant. Maybe they have a favorite topic that they like to talk about, and that kind of relaxes them. having these little notes is important. Again, my lead assistant is the one who puts these little notes in the chart, and she reminds us every time on our morning huddles. So if you have that person on your team, that's great. That's fantastic. If you don't, you have to find that person. Medical coordination. This is typically done by our scheduling team. They're very, very good at it. They will send a fax. If they don't hear back within a week's time, they will call, then they will call again. They will send another fax. They will sometimes email. And if none of these strategies are working, then they will contact the power of attorney and tell them that, hey, I have tried 3 or 4 times getting in touch with the medical provider. I've had no luck. Can you help me? And that's when maybe things get a little faster. But make sure that the information that you're asking for is as direct, as straightforward as possible. Ask specific questions so you get specific answers. If you don't ask a question, remember you're not going to get an answer. You're going to see a sheet that comes back saying tick mark, dentally they are medically cleared for dental procedures, which doesn't help you at all, right? If you don't have a fax machine, maybe now is the time to get one, because most medical practices and hospital systems are still kind of old school and prefer faxes. Most of them, they're kind of like pharmacies, they prefer faxes over everything else. So you might need to get a fax machine for this, or you could use an online system that can supplement as your fax machine. Um, Communicate with caregivers pretty well. I feel like sometimes using scripts can be very important if you're training a new person to answer phone calls and to make new patient appointments. Using scripts can be pretty nice, but really they need to be preparing the caregiver for what to expect at the first visit. Tell them that, hey, the patient, the appointment might not be very successful. We might not get x-rays done. We might get only pictures done. We might get only a toothbrush prophy done. um, and that can also be the same time during which we are gathering as much information from the caregiver as possible. When was their last dental visit? How did it go? If they haven't seen a dentist in so many years, why have they not seen a dentist? um, so many questions that come before you ask things like insurance. Do you guys have insurance? No, that's the last question we need to be asking. Um, I typically have our schedulers ask things like, how does their blood work appointment go? Do they let them get, do they let, the phlebotomist go ahead and prick them? Or do they need to be held down? How does their haircut or hairdressing appointment go? If patients are pretty compliant going to a hairdresser and having their hair cut by a different person each time, then that's a pretty good indication that they will sit in the chair and follow instructions. So I typically have them ask all of these questions in advance so we know how to prepare for the appointment and it can be as successful as possible. If they display aggression, self injurious habits, any of those red flags we talked about, they need to be given OCS. So then the scheduler will say, hi, can we get the primary care physician's information? I'm going to review all of this with my dentist. And if my dentist says that we need to have them taking some kind of sedative or benzodiazepine, she will contact the medical provider and have them prescribe that in advance so the patient can take it before they come see us. And typically, caregivers will be totally fine with that. They will give you the primary care physician's number and their email and which hospital it is. Preventing burnout, we so I have a philosophy that if you love what you do, you will never get burnt out. But of course, everyone gets burnt out at some point, at least emotionally, you're completely drained. So sometimes if you limit your patients with special healthcare needs to maybe one or two a day, that might be a much better way to do things. Have a debriefing session, at the end of the day. Maybe it could be just you and your lead assistant, or you and your um, office coordinator, whoever you're just on best terms with, whoever's kind of in sync with you, with respect to how treatment is flowing through the office. Maybe you can have these debriefing sessions with them so that all of you feel kind of mentally at peace at the end of the day. Um, we typically do that um, right when we are leaving a patient's home and we're going into the next ones. We will just talk about how things went, what was successful, what was not, and that's kind of our way of debriefing, but it helps. The last thing is insurance. I kept it for the last because really the first question should not be, do they have insurance? It typically upsets a lot of families and a lot of patients when we focus on insurance so much. And I will say that most patients with special healthcare needs actually do not have insurance. They will be out of pocket. They will be fee for service patients in your practice. Um, some of them that do have insurance have state insurance. I'm not encouraging you or discouraging you from taking state insurance, but what I will say is that state insurance may or may not be practical for your practice. That is a business decision you have to make. However, if you do see a patient with state insurance and you don't take it, you can always tell them, we don't take state insurance, but I would absolutely love to help you if you're willing to pay for these procedures out of pocket. So you have to give patients the ability and the opportunity to let them know what kind of value they're going to be getting from seeing you at your practice, um, rather than just closing the door and saying, we don't see state insurance patients and we cannot help you. Of course, many of you watching this do see state insurance patients, and that is absolutely fantastic. Um, but it definitely adds to your burnout level because many patients that are on state insurance are also dealing with lots of other issues with regards to their medical health, and they do tend to bring all of that emotional burnout into your office, which can be um, very difficult and challenging for us to deal with. So remember that. Protect your energy at all costs. Business benefits. Um, these patients with special healthcare needs, can be some of the most loyal, loving, and rewarding patients ever. They will not only stick to you until you die, but they will send lots and lots of other patients and family members over to you. They are a great practice builder, so I absolutely encourage you to see patients with special healthcare needs in your practice. They also have a strong sense of case acceptance. They do want to get treatment done. It's just been difficult for them to get treatment done at other offices or with previous experiences. And if you show them how they can get treatment done at your office just by being very, very patient and kind with them, you will find yourself so busy because they usually will never say no to treatment. They do want treatment to be done. Um, there's different ways in which you can market to this community. Of course, there's SEO, websites, your social media. Your website should be ADA accessible. There are some guidelines that are published with the American Dental Association that tells you exactly how you need to comply with those guidelines so that someone with um, a hearing disability, someone with a visual disability can actually access and understand your website and make an appointment, right? So you have to follow those guidelines, and you can make connections in the community as well. But I found that most patients actually just find us through word of mouth. They tell each other about us, and that's how they find us. Or they find us through their primary care physicians or their cardiologists, sometimes from their physical or occupational therapists. Remember, I said that most of us work in really tight circles and everyone seems to kind of know each other. That's how people find us. So, once you start seeing a couple of patients in your community, they will spread the good word and tell other people about it, and that's how they will come into your practice. And of course, Special Olympics is also a great resource for getting new patients in the door. Um, this is a referral form that I came across just a few weeks ago from a dentist in my community who had actually referred a patient of mine who became he was a patient of theirs before they became a patient of ours, and they had actually been referred to operating room dentistry because of poor compliance. He has written, patient is uncooperative, very challenging, aggressive, agitated, couldn't sit properly during treatment, and hence they need to be seen for hospital dentistry. And I wanted to grab a picture of that because it was in stark contrast to what we saw happening at our visit. And um, what did we do differently in our visit? Really, nothing much. I found out what happened at the visit at this dentist's office because the caregiver told me that this dentist was very busy, that the patient and that the caregiver themselves were waiting in the waiting room for almost 2 to 3 hours. So that sounds like a practice that was extremely busy, right? Not just busy, but extremely busy that someone had to be waiting so long. So by the time they were done waiting and had to go in for treatment, my patient was just super exhausted and obviously very agitated. I would be agitated if I had to sit for 3 hours in somebody's waiting room, right? You run out of things to do. So, that is one thing that we don't do at all in our practice. We don't make patients wait for more than 5 minutes. And preferably, we have them kind of do what they are doing. If they're watching TV, let them watch TV. If they're reading a book, let them read a book, let them eat while we set up. We don't want them to sit in front of us while we are setting up, watching us set up, because all of that kind of builds some amount of anxiety. We also have very small bite sized goals for every appointment. As a rule, I never numb on the first visit unless it's an emergency situation. Um, I don't like doing that because it's not a good way to build rapport with patients. And if patients don't do well for that appointment, they will never come back. I have seen that happen before, so I just try not to do that. Um, we only focused on photos for this patient's visit because we knew he was coming from a not so great experience in the past. But because the photos went so well, we attempted x rays and he did great. So, having small bite sized goals for every appointment is another thing we are doing a little differently. We're also just observing patients and we are super patient. Like I said, I try to give patients at least 5 visits before I kind of look into trying something different like sedation or operating room dentistry. I like to give them that time to get used to us, to get used to my team, and to try and get them to comply with just sitting in the chair. And I have never actually in the last few years have had to use those 5 visits because we tend to get compliance way before that in visit 3 or by max by visit 4. This is our last case study for our lecture series, so I hope you're kind of excited for it. This is another one of my really sweet and favorite patients. Frail elderly male, 81. He's 81. And the first time we met him, he said, I have a couple of broken teeth. I'm just wondering if they are infected. You look at his medical history, pretty blank-ish, right? For an 81-year-old. He's had a heart valve replaced. He's had some scarlet fever. He had the heart valve replaced in 2023, not taking any blood thinners, never been asked to take any antibiotic before dental visits, and no osteoporosis either. And this gentleman is like a very frail looking man. He has a full time caregiver, around the clock caregiver, buzzing around him. So, again, Sherlock Holmes, right? Something is kind of missing. So we asked for the medication list. Lo and behold, that's a lot of medications. He's on amlodipine. He is on Ensure. He is taking Januvia. He's taking metformin. He's taking levothyroxine. He's taking venlafaxine. So he has a lot of stuff going on. He has an enlarged prostate. He's taking selective serotonin reuptake inhibitors. He has diabetes. He's taking some supplements to improve his weight and his health. He also has hypertension, none of which he mentioned in his medical history. Even though he has beautiful handwriting, he did not mention any of this. So we had to dig a little deeper and get a full medical history from his physician before proceeding with treatment. And then you see his teeth, right? He's definitely had some dentistry done over the years. He's had some crowns. Unfortunately, some teeth have now kind of broken down, right? There are lots of little root tips left in his mouth. Lots of root tips. Some questionable crowns, but are we going to really take them out and try and do more treatment here? Not specifically, unless the teeth are kind of mobile. If teeth are looking pretty stable, they're not mobile, there's no big fat decay under these teeth, I usually will try to leave them where they are, especially since he's 81. But the root tips in here, again, it's a question, right? Whether you will take them out, you leave them where they are. Different providers will end up doing different things. And that's a question for you. This is what his mouth looks like. Obviously, you can see that there's some kind of gingival inflammation. Is he wearing some kind of partial that we don't know of? Maybe he is. I didn't see it in his pictures, so maybe he has one and he just took it out that day or forgot to put it in. If he forgot to put it in, why did he forget? Is he undergoing some kind of cognitive decline, which is why he forgot? These crowns also don't look so great. There is some plaque and tartar around these teeth. Social history, as I mentioned, full-time caregiver support. We have to call his caregiver to schedule appointments because he does not have a phone. He lives alone. He does not have any family close by. He needs help with pretty much everything: toileting, meals, going to bed, every single thing. So, someone with full time caregiver support, you have to start to put pieces together and start realizing that, okay, this patient um, is really, really quite medically fragile, and we have to be careful in proceeding with treatment. So you can decide here whether you choose to go palliative or whether you want to do comprehensive treatment, whether you seek a medical consult, and if you do, what do you ask them? The biggest thing that I would have probably wanted to know is how is his diabetes managed? He does not seem to be wearing a continuous glucose monitor. So I want to know what his last A1C was, what that score was. Typically, if it is above 8, I'm not really pleased with it. If it's above 10, I'm definitely not doing any treatment because the risk of infection is far too high. These patients need to be better controlled. If they're over 8 and they're not even on insulin, maybe their medication needs to be adjusted to get it to be controlled. If they're around 5 or 6, it's still okay. What in the medical history concerns you the most about this patient? I think, of course, the fact that he has some kind of rheumatic, some kind of valvular replacement and has not been on any antibiotics before dental treatment is a little questionable because he probably should be on some kind of antibiotic. That is something that you need to check with the primary care physician before you start prescriptions for those medications. I think the other thing that we were concerned for was just the diabetes, um, but nothing else really concerned us as much. The diabetes also helps explain why you see so many root tips and why you see his gums not so happy with things. Would you extract teeth? Would you fabricate partials? Does he have existing partials? Again, we talked a little bit about the cognitive decline a little while ago. You want to start looking out for those five M's that we talked about in, I believe, module two, the geriatric five M's. You want to be looking out for those. And do you do anything else? So, this patient was seen by two different providers. It was myself and one of my colleagues. And my other colleague is very, very palliative, whereas I am more comprehensive, which kind of makes sense based on our age groups. I'm a much younger doctor. My colleague is a much older doctor. And um, when I came in to see this patient, I did see how medically fragile he was, but I also saw that his teeth were not in great shape. And I was concerned that if any of those teeth were to get infected, it could become a big problem, especially looking at his diabetes. So I decided that I wanted to remove those root tips and not keep those root tips in. He did have a partial, which was no longer functional because some of those teeth it was retained or sitting on were broken down. So we had to make new partials for him. I was a little concerned about how his extractions would go, but he actually did so well for those extractions. He surprised all of us and was a complete trooper. He did great. He barely required any anesthetic, and those root tips were challenging to take out because again, I even though he was not on a blood thinner, I always try to be as atraumatic as possible and I go for simple extractions because I don't want to remove bone or affect his gums in too much of an adverse way. So even though those root tips were a little tricky to remove, we still got it done and he healed beautifully. So that was my little spiel on how you change treatment plans based on just different patients. I hope you come away from this lecture series feeling inspired, feeling more confident about seeing these patients in your practice, and about increasing access to care for our patients. We need you. We need you to be seeing these patients in your practice so that we help improve healthcare outcomes for everyone. Thank you so much for being here, and I hope to hear back from you about feedback or any questions that you may have. Take care.